Ready to go.
Okay. Welcome, everybody. It's Tuesday afternoon, and you're at CCAC as usual. Glad to see you. Thank you so much for all of your feedback on the document today. I've been incorporating all of it as the day has progressed. And I want you to know that last night at about 10 o'clock, I was about to respond to a message from Chris. And in that message, I was going to write something like, I've sent the document out to CCAC and I've gotten no feedback. And as I was writing, I thought, and I've gotten no feedback. And so I checked that drafts folder again, and the same thing had happened. That happened to me before. It did not send when I had intended for it to send. So I apologize for that. But people have sent really good comments. Almost all of them I've incorporated. There were a couple of things. I did keep the questions at the beginning. I put a little more context around those questions so that it didn't feel quite so much out of order. I think Rich had brought that up, maybe that seemed a little odd. But most everything was, pretty easily addressed. So, so thank you for sending all of that. If it's okay with the group, the co-chairs and I will just clean that up and send it out, unless you would like to see it again, just before it goes. Because what I'm hoping is that we'll be able to kind of have the folks that are in charge of implementing these things and sort of putting the community standards together and doing the communication come back, just as the testing folks are coming back to us today. They would come back and give us an update and show us how they've incorporated some of the things that we're suggesting and bringing up in the document. Does that sound like a reasonable plan? Can you give me a thumbs up or a head nod or a absolutely not or something? Okay. All right. Terrific. What I know about our meetings going forward right now is that next week, the chancellor wants to join us and talk a little bit about, where he sees things going from here. I think wants to thank the group for the hard work that we've done thus far. So we will meet next week. We may have other agenda items for that meeting as well. I'm not quite sure, but we'll kind of see how that goes, and I'll keep you posted during the week. We all will keep you posted. So today we do have, you saw from the agenda, an update on testing and logistics and procedures and protocol. And Dr. Amir Barzan is joining us to talk in particular about a whole testing protocol that's been designed that give us those details. Along with Ian Buchanan. Dr. Buchanan is at the ambulatory and post-acute care for UNC Healthcare. And I think both have been involved in a testing protocol in the labs, in the places where testing will be delivered, in apps that will be supporting that testing, all of that kind of thing. So coming back to us after our recommendations to kind of let us know how that's going and seek a bit of feedback on that. So that's really our main agenda item for today. We might actually end on time. That would be a happy circumstance, I think. So with that, I wanted to ask Dr. Barzan and Buchanan, do you want to present sequentially and then have questions and discussion? Or would you rather have one of you start, questions and discussion, next person? What makes sense from the content?
Ian and I work best as a team, I think. So what we'll do is that we'll kind of present together, and he'll fill in parts where I'm void, and then I'll fill in parts where he's void. Okay. But I think that we both would agree that at any point we can kind of do it in a few different ways. It's easy for me to walk through maybe a generalized plan, and then we can stop even in between to discuss, or if it's best for the group to kind of just get their bearings and an understanding of like an overall spectrum view, and then work through questions that way. I'm happy to do either, Mimi, whatever you feel like is best.
Is there a feeling from the group about what we'd like to do? mean, unless something is, really unclear that sort of keeps us from moving forward, my suggestion would be for you all to go ahead and present the full scope, kind of on the assumption that some of the questions might be answered by whatever else was going to be presented. So try and get that on the table first and then respond. Does that sound like a plan?
That sounds great. And I think Sharon had commented that that sounded like a good plan too. So
Good.
why don't we go ahead and do this? First and foremost, thank you all for allowing me to come back into your space and to just put some more insight and maybe some more data and some more elements behind what we had talked about before. Just as a way of reintroduction, again, my name is Amir Barzin. I'm a family medicine physician. I'm assistant professor in the Department of Family Medicine here at the School of Medicine. I think that this is actually the first time that you have seen Ian. So Ian, do you want to introduce yourself?
Sure, I'm Ian Buchanan. I'm president of ambulatory and post-acute care for UNC Health, working with our outpatient practices across the state of North Carolina. I've been a member of the Chapel Hill community since the late 90s when I came here for medical school, and I've been back at UNC continuously in a leadership capacity since 2008. Happy to be helping.
So just as a way of introduction, again, in terms of what we were doing, we've been working together as a campus and as a team that spans quite a few different disciplines. And I heard Mimi mention a little bit earlier about other people who have come and presented to you, as a way of just kind of rehashing and going over again what our scope that Ian and I are most closely involved in. It's really the basic principles and the tenets of trying to figure out testing, contact tracing, isolation, quarantining, and then basically continued care for our students, but also thinking of how that plays in with the community at large. I see a lot of you have mentioned here in the comments talking about the positivity rate across the state, but then also looking at it on a more micro county level as opposed to a global state level. And I'm glad that you're mentioning that, and I'm happy to talk more about that as well if you would like. So I'm going to walk us through just a few things. And again, this is very informal from my perspective and Ian's perspective. We're here to share information and to gain feedback. So feel free to interject at any time that you would like. Just a little bit of framework for what we're going to discuss today. We're going to discuss some basic key principles or key policies that I think would be helpful for having some feedback and discussion on. That will include what I'm referring to as prior to arrival kind of procedures, the testing and surveillance that would continue during the time of someone being on the campus footprint. And then again, as I mentioned, more so the discussion of what happens to people who need extra assistance, extra medical care, et cetera. If that's a fair platform for y'all, I'll just kind of jump in. And then if there are other points along the way that you want me to talk about that may not have been in those three big buckets, feel free to drop it in the chat and I could definitely incorporate it into the thoughts. So just a little bit about what we had talked about before, but also to kind of make sure that everyone is starting from the same ground if people weren't at our meeting beforehand. We really have worked in trying to define what is a safe return to campus policy, but also gives us the most chance to succeed in a few ways. And when I say succeed, what I think about that is keeping our faculty, staff, students safe, but also giving us a chance to be able to expand the coursework that we're doing to include in-campus classes if possible. And then also being sure that when we are doing this, we're doing it with a few principles and tenets in mind. We're going to use good science behind the way that we're coming up with the ideas of frequency of testing. We also are thinking about it in an adaptive model. What we may start with right now may change based off of hopefully slowing down a transmission, but if it goes the other way and there's a higher rate of transmission, we could adapt and evolve that way. So again, please remember that this is a fluid model in what we're talking about. So the first thing to talk about or to discuss is what we're calling a little bit of prior to arrival testing, right? So I use that term instead of re-entry because I think re-entry sometimes gets confusing because it sometimes has the connotation that we're doing it at the time of the student being on campus and then re-entering the community then and there. So prior to arrival, what we would like for students to be able to participate in is about 5 days prior to coming to campus. We would like them to be involved in getting either an antigen test or a PCR-based test that shows their status of having SARS-CoV-2 or COVID. Why this is important and why this is different than in the fall semester is that we have a lot more data at our fingertips on what's important in terms of understanding the virus. So if we start by having our students get a test prior to coming, what we do is have a really good number. And when we've talked to other people about this, like our University of Illinois and our Dukes, what it helps is saying we can at least try to limit the number of people that could be coming to campus that are positive before the classes even begin. So we think that that's a valuable tool for us to start on the right foot. I do want to emphasize, and we should continue to emphasize, and please ask me about this as much as you would like, a test is only a snapshot in a picture in time. It's only as good as the moment that you get it. But what we want to do is use powering of frequency and surveillance to get us closer and closer to knowing that our highest risk of transmission is being monitored very closely. And that's what a surveillance plan grabs us. So again, prior to arrival, our undergraduate students, let me underscore undergraduate students, would have an antigen test or a PCR-based test done in their home communities 5 days prior to arrival. After that occurs, then we have a review of the documents. It allows us to be able to say, okay, if you're positive, ideal state right now is for you not to come back to the campus community. It's actually to finish your isolation time in your hometown at the discretion and at the intervention of what your county health departments are telling you. So that I think is really important. When we've talked to our sister campuses that have done this, even with doing that, there are still some people who come back to campus that they catch on day one of the surveillance testing that are positive. But again, the goal is to shrink that number to as small as possible. What we think would help us in phases going forward is when you come back to the campus, we would administer our test, which we're calling our program that we're doing this because of the wider net of Carolina Together. This is the Carolina Together testing program, is what the broader bucket of the testing would fall under. Would be an idea based off of your presumed interaction with the campus and where you live. We know that higher density living areas make spread a little bit more of a problem. So thinking of our dorms, our buildings that have more than 10 occupants at a time that are living in those spaces, not necessarily a classroom space, I'm sorry for that, or those that are living in the immediate Chapel Hill, Orange County, Durham County, and Chatham County areas are the ones that we really want to help address. So if you're an undergraduate student and you're living in one of our on-campus living houses, what we would want to do is on your day that you're moving in, and the plan right now is like a staggered move-in for the dorms, to be able to come to you with the testing supplies, and at time of check-in, you will actually administer your first UNC administered test. The UNC administered test would then be run in our UNC lab that we have set up, or in the process of finalizing the entire setup for. And we would have your result within a really critical time period that we think that the testing really needs to be prompt. So less than 24-hour turnaround time is our goal for turnaround time for our tests. And again, this is a anterior nair test. So it's a nasal test, but basically goes no deeper than the side of my nostril. You swirl around for about 10 to 15 seconds. You take out the Q-tip and you go to the other side and you swirl for 10 to 15 seconds. The reason why we're recommending this test as opposed to a saliva-based test, it sounds counterintuitive, but this is actually a faster test to perform. Saliva has a lot of indications that you have to kind of follow. You can't eat or drink 30 minutes before doing a saliva test. You can't just, for better or for worse, spit just into a cup. You have to really work up the thinner saliva, and that can sometimes take up to 2 to 3 minutes to get thinner amount of saliva, the amount that you need. You can imagine in this situation, it's really 30 seconds. You put your swab back into your vial and you're done. So it's actually a faster administered test. Our colleagues at Purdue have actually converted from saliva to nasal-based testing because it is actually it takes away a lot of the problems that they were noticing in terms of their false positives or their inconclusive results, and then also the timing. So I think we're starting off on a better foot by doing the nasal to start. We would do that depending on where you live on campus and how frequently you're coming to campus, a variable amount. So we are still working with the roadmap implementation team to understand the exact cadence of what this could look like, but would imagine that probably twice a week for those that are on campus a little bit more and living in those dorm spaces or higher congregate settings. And then for those who are living in the community, but maybe just doing, for example, just all remote learning, that would be one of the things that we would do on a less frequent cadence for the undergraduates. And Tom, you asked a really great question. There are testing sites, but what I wanted to say is that for the very first, for the move-in, we know exactly when the students are coming to the dorms because you have to sign up for your move-in. And so we actually think we can, with our staffing that we have, actually go to them for that very first site. So we know, so like when you're checking in, you're getting your keys, you're doing your checklist, again, 30 seconds, we get your first test, we know that you're there, you're done, you've checked the box. We do have testing sites that are planned across campus. We've thought about this quite a bit, and some partners like Illinois have quite a few. They're testing in the magnitude, they've almost done 900,000 tests over the past year, quite a bit of tests. So they have about 15 or 16 sites that are scattered all across their campus. For what we thought of, you get variability with sites as you get up that high. They also have a lot of temporary structured sites, which when we were thinking about the time of the year when we're starting this, that's nice when it's summer and spring, but when you're starting off with the weather being colder, we didn't necessarily think that it would be very helpful to have outside testing sites. So we, as opposed to saying, let's do more testing sites with fewer lanes, we did the opposite approach. Let's do fewer testing sites that we can control in terms of having less variability, but have more lanes that are appropriately stationed out. So we're thinking of 3 testing sites, anywhere between 15 to 18 lanes. Even if you say that you're doing a test for over a period of 5 minutes, this still leaves us the possibility to do way more tests than we need to do on a day-to-day basis. And I'll address that question to Ryan for you. So, so that would be kind of what they would come to in doing their regular cadence surveillance testing. We do think that one of the things that we've seen from a healthcare standpoint that I think is very important for this group, but also our larger community. We have worked really well in our healthcare system to define the ability to not have to blanket test all the time, even people that are working in healthcare that are taking care of patients. We do that because we have this symptom checker that we're doing on a daily and consistent basis. So we think that faculty and staff doing that symptom checker does a couple of things. One, it gives you an option to be able to really report adequately what your symptoms are and whether or not you should be coming to work. And then 2, if you do need a test, it actually routes you to making sure that you have the appropriate occupational health address needs done too. So we are thinking that we will work with our campus partners and faculty and staff, that if you are coming to campus, we are going to basically have it so that you could be tested on a volitional basis, probably in the magnitude of up to 1 time a week, if that's something that you desire. I'll go back to the testing site and the clarity about the timing, because 2 questions came up. The tests and the result have to be done within 5 days prior to coming to campus. So they would have to basically do it within that day. So let's say you're coming back on the 13th you do, let's go back from that, 12th, 11th, 10th, 9th, 8th. So between the 8th and the 11th or the 12th is when you would want to do it. One of the things that's kind of nice is that antigen tests, depending on which one you get, sometimes are as fast as 15 minutes. So that's the benefit of an antigen test. It's not as sensitive, it's not as specific, but it is helpful. So that's where the window is. And we're working with the communications team to make sure that that's clearly marched out and that communication is very much presented in a clear way for people to digest. In this testing protocol too, what we have is that we're working very closely with our partners in information technology to make sure that not only is the test being processed, but once we get a test result, it's just a test result. It doesn't help us in the other aspects of what we need. So we are bridging the information necessary to the state to have our adequate reporting done. We have what's called a lab information management system that we're working on procuring so that we can make sure that that's done in the right fashion so that the state gets all the data that they need, but also in a way that we can report back to the people who are doing the test, their test result. We're working with Stephen King to develop a really nice mobile interface called Hall Pass. This is going to do a lot of things for us. It's actually the entry point for the testing. So when a student walks up to a testing site, and I brought props, so bear with me here for a second. This is, for example, the tube that they would have. They would snap a picture of that tube with their phone. That links the person to the test. They then take their swab that they're going to use. They do their sample. They put in the swab in the tube and break it off. The nice thing about this barcode is this is the actual barcode that is going to run through the machine. So we actually don't have to unhandle and rehandle stickers. We basically can use on our machinery one code 128 barcode that runs throughout the entire process. And that's what we use throughout the rest of the whole process. So hopefully what we're trying to do is minimize any kind of one, injury to staff for repetitive use of opening and unscrewing caps, but two, make it so that the process is really streamlined. We do understand and we very much appreciate the fact that sometimes your phone may not be working, sometimes your phone may not have a camera that's active. And so we will have the ability with the people that are helping staff the sites to be able to input the identification necessary with a PID and the test number so that it links the test to the person. And then after that, the test goes to the lab is run, and then we do our reporting on the back end. We are working very closely with Campus Health and Orange County Health Department so that whenever we do have tests that come back, that if it's an on-campus student, they receive the appropriate instructions, but also are working with the housing team to move them into the appropriate dorms. The other thing that we're doing is that we are preserving the function of Campus Health. So Campus Health will continue to see patients. They will continue to do symptomatic patient testing, and they will continue to do close contact testing as well. So what we're doing right now is giving Campus Health kind of a bridge out of what they're doing right now with continued surveillance asymptomatic testing so that they can focus their efforts on being able to do the care that's necessary to keep our campus community safe and to continue to do the things that they do really well, which is care for students that go to a university. So those are basic tenets and principles that we wanted to go over and to kind of make sure that people understood. Ian, are there extra points that I missed that you wanted to add or just kind of clarifying points that are in there?
I would just add that I think also somewhat differently than in the fall semester, although I wasn't involved with that process, the university and Orange County Health Department, we now have a very robust contact tracing plan. We know just based on the characteristics of COVID and based on the characteristics of asymptomatic testing that there will be cases in the campus community. There's just no question that will happen. And when it does, Orange County and Campus Health are well positioned to do very rapid contact tracing with those students. And then if those students are living on the campus has good planning in place for accommodating them in specific dorm rooms and feeding them and making sure that they've got their needs met and that sort of thing. So good planning has gone into that process.
And one other thing that I mentioned, that I didn't mention, is that I touched on at the very beginning. We're working with a team of epidemiologists and our public health experts to really help us understand what you guys put in the comments at the very beginning of this, which is if the community spread gets to X in Orange County, what would be the understanding frequency of what's going on and in terms of the potential rate of rise? So do we have to scale up testing so that we can capture more people because we have a geographically dense area that may have more relative cases, or can we scale down? And this is what our partners at Duke have done. Very much in this process, they kind of review their epidemiologic data and they go up or down on their testing frequency based off of what happens. And sometimes they completely exclude a subset from continued weekly to twice weekly testing. So in terms of the frequency, Kira asked this question: how do we plan to monitor who is getting tested when? And then Aaron mentioned as well, how often might a student be tested throughout the semester? So we have two of those. So we, in terms of the question that Aaron asked, how many times they may be tested, if you're on campus, if you think that you're tested potentially 2 times a week in a 15-week semester, you may get tested 30 times. That's for our undergraduates that are living on campus. Graduate protocol, again, what we think is that there is not necessarily as much spread in terms of graduate students as what we've seen from learning from our other partners, but we do want those that are coming to campus to be able to get tested. And so if you are coming to campus and you're a graduate student, whether that be because you're taking classes, teaching, working in a lab, we are saying once a week for you. And then yes, in terms of having faculty and staff, again, volitional protocol there in terms of potential testing, but we do want everyone to do a daily symptom checker. And I actually believe that there's talks that that is going to be kind of a global thing. But I think that that's one of the things that, again, for those that are coming, one of the things that's nice about doing a symptom checker where surveillance testing doesn't pick up. One of the questions on the symptom checker is, have you had close contact with someone who has had COVID, or do you live in a household with someone who has had COVID? We would not want that person necessarily to come into the workplace because they're at higher risk and they may be exposed in pre-symptomatic/asymptomatic. So that's what a symptom checker picks up, that testing frequency wouldn't necessarily.
Amir, I have to ask a quick question regarding the prop that you held up. Is it at all possible for us to get a slightly larger vial so we wouldn't have to snap the cotton swab?
Yes. So I'm sorry, that wasn't the exact one. Let me show you the exact one. So I will do the whole demo for you. So this is the size of the tube. This is a we're going to get real dorky for a second here with science. So this is a saline-based solution that's here, but this is a 100 milliliter tube, millimeters height tube. So when you take the cap off of this tube, you can actually use this swab. And this swab, the swab was probably the hardest thing to find out of everything that we had to get in supplies. You imagine a Q-tip. There should be thousands of these. So there was only about 1 million in the world left of these. And we managed to find a supplier that got us a large portion of them. So you can put this in, there's a break point on this swab and it just breaks and it just fits completely in there. The nice thing about this cap that we will use on the back end is that if we actually unscrew it, the swab comes out in the cap. So it makes our processing a little bit easier.
I think though, this may be part of your question, Mr. Watkins, the snapping off is actually important to the test because while this is clearly not a sterile specimen because you just stuck it up your nose, you also don't want the part that you've been touching with your hand to go into the vial because it risks contamination of the test. So there actually is a functional reason for that. It's not just a mismatch in the tube size versus the swab size. So I just want to clarify that.
We are working with our partners to make sure that those who are not financially or logistically able to access prior to return testing, that there are options for them. That was very important for us. So we're working with our partners, both in communications and in the deans, the student affairs office, to be able to do that. The other question that you mentioned about the testing and how will you know? So based off of Hall Pass, the application, we have the ability to build in our testing timeline. So 72 hours, it would trigger you to show being, having a banner that says you're compliant to testing needed, and you would go in. And the group that's working on kind of what you had mentioned at the very beginning of what you were probably going to have people come back and talk to you about is what are the actions if you're non-compliant with the standards, the community standards.
So let's talk through the testing for the different student groups. So we've sort of stratified groups into risk levels, the risk that their interactions with one another present to the campus community as well as the larger community. So Amir had mentioned the undergraduates living in dorms or living in Greek houses or living in Granville Tower. Those are fundamentally congregate living situations, right? So that's the highest risk for having an outbreak. And initially, we'll be testing those students twice a week. That's consistent with other successful university efforts around the country and consistent with the test and epidemiology characteristics. As Amir mentioned, we hope that over the course of the semester, we can fine tune the testing, working with Audrey Pettifor, who's on the call, as well as colleagues, develop a more sophisticated epidemiologic model so that in some areas we might be able to actually scale down testing as we hopefully keep the prevalence low in those areas. So, but that's the maximum is for students in those high risk settings, it would be twice a week. For undergraduates who are living off campus, but in one of the adjacent counties, so Orange County, Chatham County, or Durham County, those students would be tested one time a week. And the idea there is that although they're not living on campus, they will be interfacing routinely with other students and with our extended community at large. And then for graduate and professional students, there's sort of a carve out here. So we've got a large percentage of our professional students who are in health affairs. So they're medical students, they're nursing students, they're pharmacy students. And because those folks are already in clinical environments, they already have their own defined surveillance and testing pathways. So they're sort of carved out. So when we're talking about grad students and professional students, we're really talking about history and biology and law and those types of schools. Those students who are coming onto campus either to teach, to take classes, or to do lab work, they would be tested once a week. And again, the rationale there is that they're coming onto campus, they're interfacing with the campus environment, but we know from the data that the transmission and the chance of outbreak amongst that graduate and professional population is much less than the chance within an undergraduate population. So they will be tested one time a week. And then graduate and professional students who are living in the immediate area but not coming to campus, they have the option to be voluntarily tested once a week. And again, that's just sort of a service that we're able to provide to that student population, but it's not really necessary per se to protect the campus community. Same thing with staff and faculty, as Amir mentioned. We know that just like as we've seen in the UNC healthcare environment, so every 24 hours we have about 12,000 people working in the clinical environments of UNC Health in the Chapel Hill area. We don't do any routine testing whatsoever. We do symptom check, and people are masked. And we know that if you're masked and you're doing asymptomatic symptom checking, that's highly effective in preventing transmission, most importantly, and then identifying early when someone becomes symptomatic. So for faculty and staff, we can test them up to once a week, but that's voluntary, and it's really, again, a service to the faculty and staff more so than it is a clinically or epidemiologically driven need to test those populations.
I'm going to show, Audrey asked me to show the Hall Pass template, and I'm going to definitely do that. And I think Ian addressed well the graduate and professional schools, but I just want to make sure that I clarified one thing from Kira's comment here. This is not a nasopharyngeal swab. It is a anterior turbinate swab. or anterior nair swab. So it's much better. So instead of going into the back of the nose and having someone administer that test, you can do this test by yourself by taking the swab and doing it yourself. For the move-in day, we are planning to actually go, every one of the communities that the dorms are moving into have a central location where they have to check in. Our plan is to be able to go to that site on day one of move-in, because we are going to know when the move-in days are and when how many people are coming on each one of those days. So we would actually have them administer test number one on that site.
Can I just ask a question about the health profession students, since you
Please.
mentioned them? They are not, we do not have a testing protocol at this point. We have a symptom checker thing that we're doing. So there's a lot of questions about that. So if we have undergrad health profession students who are living on campus, I assume they will fall into the surveillance testing you're talking about now.
That's correct.
Correct?
Yes. Undergraduate, yeah.
Right. And if the health profession schools want to be in the testing protocol, can that be discussed about how we can have them fall into that? And that another question I have is, how do you know who's coming to campus? You're saying you're going to test the people who are coming to campus. How are you going to know who's actually accessing this campus that hasn't been tested?
Yeah, so we are going to kind of a couple of different ways. One is that we have rosters of active classes, correct? So we know that who is enrolled in the on-person classes. We would also know who is living in the dorm rooms or those congregate settings of more than 10 people. We would have that list. That's a defined list. If the other part about this is that, and maybe this is where it's helpful to show this, and I'm going to do this right now real quickly. So this is what that hall pass looks like. When you come in, you log in with your Onion, you have your agreement to your terms, you confirm your mobile number, your ability to kind of get a test done. You can go through this where you actually find your testing sites. Again, this is not done yet. These are just placeholders. You can actually look in here and kind of confirm the time that you would want to do a test. And then after you reserve it, you basically have your QR code that you can use to quote unquote skip the line. You would then have this little banner that shows that you're compliant with the testing program. So if I'm coming into a building, I could show this to a person who is helping kind of watch the ins and outs of the building to show that I'm compliant. So if I have my green pass that says compliant, that'll be a visual to let people know that. If I have my red pass that says test needed, it's a reason to not allow them into the campus.
So you're basically only testing people who are coming into class, not necessarily people who are coming onto campus.
You're testing anyone who's coming onto campus, and you're testing anyone who's living in the immediate for undergrads, anyone who's living in the immediate 3-county area. And the question of how do you know they're getting tested? Well, in large part, this is related to the differently defined community expectations of students this semester as opposed to prior semesters. That this is a requirement of being enrolled in the university and attending classes, whether online or in person.
To piggyback off of Joy's question, I think my same concern was, how will you all know who is living off campus? Like, or will we be collecting leases? Because I think we tried that in the fall. How can we verify who's living off campus if they are not taking anything on campus?
Yeah, so that's a great question. So part of this is the code of conduct, right? The code that we're saying that the students are going to agree with being part of this is that part of that is that they are going to share the active address in which they're living. And so if they don't put their active address, then that is they're presenting to us there that there's a violation of their honor code or their code of ethics or the standards of being in the community. So the things that we're asking for students to do before they come back is to verify their address, their name, their age, where they're living, so that we know their local address, so that we can be able to trace accordingly. And then also it's important for classes. So if you have asynchronous classes and you have people in different time zones, it's important for that instructor to know who's on the East Coast and who's at home in California and when that class can meet and what the hours are around that. So we want to verify the addresses. About the health professional students, again, there's high value in having that symptom checker protocol in play. For the graduate students, what we have seen again is not that we're having large outbreaks because of people being health professionals and being in those environments. It's usually the congregate type settings that put that. So again, the risk factors that kind of put someone into a higher risk versus lower risk is helpful in thinking about that. Yes, Lamar, it is a web-based application. So it'll be accessible not only in an app, but also in a web page.
It
And
looks
will-
like there's a, oh, sorry.
Go ahead.
I was just going to ask, will buildings be such like, so say I'm living off campus and I come to go to the gym or I come to use the library. To get into those places, do I show my hall pass to say that I'm compliant as an off-campus student?
That's a good question that we should take back and kind of digest. I'm not, I would need to get.
That
a
was
better-
my question is you were saying on campus, how do you know people are coming on campus? It's not
Yeah.
just the people doing on-campus classes.
Got it. So your question is more of the, let's say the Rams Rec Center, let's say student union, let's say, et cetera, you know, what's that looking like? Okay. Thank
The
you.
casual and social participant.
Yeah, I mean, Dr. Barzan, I think one of the things we've talked about as a group is, you know, given sort of the public nature of our campus and even amongst public institutions, we're an open campus, right? And so I think a lot of the conversation amongst this group is residence hall, different conversation, right? Dining facility, perhaps different conversation, but many buildings on campus are relatively open access. And so there's just been a lot of discussion, I think, amongst this group about sort of what would that mean? Would that mean like show pros standing at the door of every single building or other types of staff? And what does that mean from a sort of cost and capacity standpoint? So I think that's just been, I think those questions are reflective of some conversation this group has had about sort of the practical and logistical nature of monitoring what is largely a pretty open and public campus in general.
No, I appreciate that. That's a very good point. And I think that our initial intent was to have some, you know, like you mentioned the term show pro, but, you know, some kind of a doorkeeper or someone monitoring to see those passes so that you would allow people to come and go. I will take that back into terms of trying to understand better exactly the larger scale of the campus for you.
It's
Reeves,
also
did you have a
important to
question?
remember that because of the way the Hall Pass app works, it will be easy for student affairs to see who's not up to date on their testing, and then that will become an issue between student affairs and the student. Now, obviously, it doesn't address the issue of, you know, if I want to come and walk into a library building on campus, I don't have a Hall Pass app, I haven't been tested, that sort of thing. It doesn't address that. But for anyone who's an enrolled student, whether graduate, professional, or undergrad, there is that linkage back to student affairs for making sure that we know who's up to date and who is not.
Yeah, we're very cognizant that even when we've talked to our partners from Illinois and from Duke, New Hampshire, we want to get this as close to 100% as possible. They have had people who have not done that, and they're had to take disciplinary actions on students. So we want to get this as shored up as possible to make sure that people who are agreeing to be part of the campus community in the spring semester really understand that our intent is we want you here. We want you to be active participants of the university, but we want to do it in a safe way. We want to make sure that you are safe, that you're keeping your family safe, but you're keeping our community safe too, because the Chapel Hill, Orange, Durham, Chatham counties that we live in, they're also part of our university community, as you mentioned, with this more thought of an open campus. And so we definitely want to do it in the safest, most peaceful way that we possibly can.
Do you anticipate requiring that you have to have your hall pass up to date to be on campus or to enter a facility on campus?
Well, so it would be really hard to do, I think, on campus because we don't necessarily have gates around our campus community, right? But
Here's what I'm asking.
Yeah.
I think there might, it to me feels a completely reasonable thing. I love this presentation. This has been so clear, specific, very, very helpful. I think it's a reasonable expectation. The condition of attending is complying with this rule. If you want to come into the library or come into a building. But But in terms of being stopped while walking through campus and asked to show your pass versus it's to enter a building, I guess is my.
I see.
So realistically, I don't know that there's any way. I've not heard any conversation about the stop and frisk approach that sounds very unappealing in a lot of respects. There's not really any utility in it anyway, right? So if I'm a runner, right? A lot of times I run through the UNC campus. If I'm on a jog through the UNC campus, I'm not going to stop and show anybody my hall pass, and nor is there any utility in doing so. The key here is that we're going to know centrally, everyone who's an enrolled student, we're going to know whether they're up to date or not. And then for anyone who's coming into a campus facility, coming inside, then that's where we come into the ambassadors and the other mechanisms for sort of checking what someone's understanding is of the community expectations and whether they've been tested or not.
Ian, that is super helpful. I didn't want this meeting to end and there be some belief that you'd be stopped and asked to show your papers or a stop and frisk. This is about entering facilities. And that seems to be a reasonable compromise between what your compliance regulations are versus the fear. I think there was some concern about tracking people's movements and stopping them in the botanical gardens.
So that's a really great point. So there's no internal tracking on this. That's a very important thing. So privacy is really important for our students. And we don't want to, this is not geo-mapping them throughout the process and watching them. I think that's a very excellent point to clarify. And I agree with you. I think the accessing the campus spaces is probably the most important thing that we do.
And so maybe we should describe it as it's a limit on accessing. It's an expectation of enrollment.
Mm-hmm.
And it is maybe a precursor to accessing indoor facilities or accessing playing fields or maybe other places of higher human contact, but not passing through campus.
Perfect.
So just to be clear, for the population that's going to be tested, if they're living in the surrounding community, right, we know where they are geographically, but they are not taking any on-campus classes, will they be included in the testing protocol?
If they're undergraduates.
Just for undergraduates. Okay.
I'm not sure if this is a better idea, but typically we're kind of used to having the raise hand function. I just want to make sure that no questions or comments get lost in the chat function. Do you think that'd be a better kind of function to be able to go through this, Dr. Barzan and Buchanan?
Sure, absolutely.
Okay, absolutely. I also had one kind of quick question. I know this is also mentioned in the chat function. I know Ryan has his hand raised as well. But someone asked about Greek life housing and if they would be required to test. I know I asked you at the Board of Trustees meeting last week about the current testing location outside, but I was curious, since that's pretty close to Greek life organizations or Greek life housing, if that would be a requirement for students who are living in those kind of houses.
Yeah, so I think that what we would agree is that when you start getting into higher density living arrangements, so what we worry about is in dorm rooms, you have a lot of people living in a confined space. And then in the other areas, what you do is that you worry about the kind of the proximity. So that's why I think we've recommended potentially that number of, if you're living in a home with more than 10 people, that you fall into the twice a week testing pool. So that I believe would probably capture Greek homes. And yes, that would be in the likely the current space. So there's 3 spaces that we're looking at and we're thinking of. We wanted one that's in probably the northern part of campus, central part of campus, and then the southern part of campus. We're still locking down the final parts of all of those spaces. So I'm hesitant to necessarily say that the locations, because I would like for the people who are involved in the decision-making of those processes to fully vet that before we agree to that. But I think that there's promise that those 3 sites will be the ones going forward.
Got it. I appreciate it.
I just want to clarify though, but so if students are coming back to live in Greek housing, is there a requirement that you know of at this point that they be tested twice a week, just like the dorms?
Mm-hmm. Yeah,
yes.
Because
okay.
Right. They will fall into that group. Likely that would be more than 10 people living in a home, right?
And importantly, almost as important as the testing is, there's going to be a requirement for all students, but certainly for students living in Greek houses, that if and when the either Campus Health or Orange County Health Department contacts them to do contact tracing, they have to cooperate, again, as a condition of participation in the campus community. That was a major barrier in the fall semester, was getting students to cooperate with that contact tracing.
I think that's definitely valuable. It looks like Ryan has his hand raised.
Thanks, Reese. So, Dr. Barzan, I wanted to go back. You talked about earlier when you were describing the testing process where students would scan the bar. I think would scan the barcode, I believe, in when they were
Right.
through the testing process. Is that also tied into the app? The
Correct. That's done through the app interface. Yeah, the web-based platform. Yeah.
Amir, let's talk for a second about the way that the data are segregated, so that segregated and then reassimilated to maximize student privacy. But before we do that, Lamar had a really important question that we've spent a lot of time wrestling with about if you're a student who's off campus and not routinely coming to campus, it's going to be a hassle. It's going to be difficult. And you're right, Lamar, and we struggled a lot with that. But where we came down to is that we know, based on the test characteristics and the disease characteristics, that the only way to try and keep the campus community at large safe is to engage in this type of a testing strategy, where if you're an undergraduate and you're in this immediate area, you need to get tested once a week. And so we don't know a better solution than that. We recognize that it's suboptimal, like a lot of things about COVID have been and continue to be, but we feel like that's our best opportunity to keep the campus community safe.
And another thing that we have talked about, Kira, is the ability to do self-administered tests and self-administered test kits. That comes with it its own unique set of challenges. University of New Hampshire does that for a large portion of their population. We may get to that point eventually, but I think one of the things that we want to do is start off on solid footing, and having monitored, self-administered monitored tests really gets us to that point to start off. And then if we get to the point where we can have dips in the volume that we see or positivity rate that we can do self-administered kits, it's not off the table for us to consider to do that. Quite frankly, it would be potentially a little bit easier side of being able to get samples back and forth. There's still there's own logistics hurdles with that, but it does have an option that others are doing, like I mentioned, University of New Hampshire. To play on Ian's comment, so what our thought is that there's this, that Hall Pass has this information about who you are in terms of your PID and your ability to log in through your Onion, so it can associate the test with who you are. When this barcode runs through the machine, all the barcode of the test sees is sample ABCDEF, and it says sample ABCDEF is positive or is negative. What happens is that the secure lab information system that we're using merges that data together so that we can put it into a report. You know, Amir Barzan was sample ABCDEF, their result is negative. And that's what we can send to the state for reporting purposes. But at no point is anyone outside of the state having access to personal information. That's not, we are actually a CLIA certified lab. So our reporting is strict. You can't have that be out of the hands of the people who have to have it. So hopefully that addresses the question of privacy and security, but also this tracking of the movement going through.
Absolutely. Looks like there's a question in the chat that since you have less testing sites, will the technology have some alerts on wait times, if any, and this will allow staff and others to know which site to use if time is limited?
Yeah, it's a beautiful question, and I think it's a great question. So yes, we have the integration capacity to do with that booking of a time slot. We can control how many people can book into a time slot. So one, we don't overrun the system, so we don't have 500 people waiting to be tested at one time. And then the second part about that is that we have the ability to kind of work with the wayfinding to make sure that there's access throughout the day. So again, we have probably starting off about twice as many slots as we would need for testing. So in a 12-hour day, we really have a potential process of that. Kim, yes,
Thanks.
our information security office is very, very, very tied into this. They are reviewing everything with a risk assessment. How long is the window for a student to be tested in order to maintain compliance? It depends on how the frequency of their testing interval. So if they're twice a week testing, that would bump to a 72-hour window. If they're once a week, it's a 7-day window. If you aren't, what we're going to do is we're going to alert them the day before that they need to get their test performed. If it's greater than 24 hours afterwards, then what happens is then they get notified that they're out of compliance, and that we would talk to the appropriate kind of understanding of what we would do from there.
Looks like Richard
Richard has his hands up.
Oh, yep.
Oh, okay. So sorry. Shifting gears, and please forgive me for asking a question that's not in your wheelhouse, but I'm curious, how has the vaccine development factored into conversations about testing, or are you focusing your attention there as well? I'm just curious.
Lucky for you, you've got two people that are probably too deeply tied in with this. So yes, part of the strategy about this is rollout in terms of the phase of how the vaccine is going to come to campus. Quite honestly, I'm using a very general pool. I'm classifying most of our college-age students as having no chronic medical conditions and in no immunocompromised state. Right now, the way that most people have like the kind of the vaccination plan in terms of tiered group, that group actually falls into tier 4, which is everyone else. So likelihood of college age students getting vaccinated based off of the way that the distribution would potentially occur would be probably 18 to 24 months away. That's not to say that there may be subsets of people that may get the vaccine based off of chronic diseases or immunocompromised states. But yes, UNC is very actively involved in the vaccine trials. We would be very actively involved in actually administering the vaccine to those, but usually it's going to be tier 1, I believe is going to be the healthcare workers, tier 2, those with chronic disease conditions, tier 3, those that are at higher risk, and then tier 4 would be kind of everybody else.
And I would just add that because the vaccine that's likely first to market has optimally a 90% efficacy, and because we know that a lot of people and a lot of students' parents are not going to trust the vaccine initially, it would be quite some time, even if the vaccine were readily available to students, it would be quite some time before we would expect to reach a level of herd immunity that would allow us to meaningfully change either our testing strategy or our, masking or physical distancing or any of that sort of thing. So we're all really excited that the vaccine is coming down the way, and it's going to provide a lot of benefit to some population fairly shortly, but it's going to be a pretty long time before it materially changes the campus's approach to what we're doing, unfortunately. But it's a great question.
And 2 questions that popped up in the chat. Yes, we totally do agree about the investment in time. We do have a chat, a text message function to be able to have the phone alerts go out to students as well. We totally understand that that's an important thing to do. Ethan, your question about testing positive, excellent question. So CDC guidance is what we're going to go off of currently. That's 90 days. So if you test positive, you should not be tested again within a 90-day window. And so that will be the way that we will feed in information to the system so that you are quote unquote exempt from testing for that 90-day period. These are really excellent questions and excellent thoughts. And again, please, Ian and I are here to answer your questions and your thoughts. We're happy to do it.
Can you say more about that, about the 90-day window? Like, how do you, so somebody is positive, they they have mild symptoms. The mild symptoms are over in a few days. And then what? I mean, how do they come back to class? And that's
So they do so by having basically what this will allow us to do based off of the banners that we would use in the hall pass. You would finish your isolation. So when you get a positive test, you isolate for 10 days and at the lowest part of it. So if your 10 days is up, you don't have symptoms, you're feeling good, everything is great, then you're cleared by the health department to come back. We have active rosters of that for our students. That's how we know who's in isolation housing, who comes out, who's in isolation via the county, who's out. So then what we would do is put that back into our reporting system for Hall Pass so that we can make sure that we integrate in that banner that basically says this person is exempt for testing at this point. So they're not going to need to have an active testing surveillance program. Once that 90-day window falls out, because we just basically say test positive, test, isolation finish this day, go forward 90 days. And then once that 90 days hits, then they'll get reminders to get back into the testing protocol.
Looks like Aaron Nelson has his hand raised as well.
Mine is a question regarding Lamar's post. It's a question for Lamar and Reeves and Ryan and Seth and Kira about what your thoughts are on student, engagement or compliance with the app. Lamar sort of raised the question, it'll take a whole lot of work to get people to use this app. Do you think that is the case if you can't get into your building without it? Or if you can't, what do you think it will take? And is there a reward system or a regulation system that you think will inspire engagement?
I'll speak briefly. I was going to say that I think my main concern was if it was only the app. I think Dr. Barsden did indicate that they can also use the website, which I think will make more students much more comfortable being able to engage with the web-based interface, especially if it still has notifications attached. I just know that we have some apps currently like Carolina Go, some other apps, Alert Carolina, that students hardly ever engage with.
Lamar, that's helpful. And I guess I think of most things that have a little widget on my phone as an app, but I guess you don't have to use the app. You can have the widget be directing you directly to the website, right?
That is correct. Yeah. And so you can actually basically, so our symptom checker that we use for the healthcare system shows up like an app on my screen, but it's basically just me saving the web page on my home screen so that when I click on it, it's always there.
Thank you, Lamar. That answered my question. I appreciate that.
I think Ethan wanted to weigh in as well.
Yeah, sure. I guess I have a question first, which is, will the symptom tracker that students will be required to fill out link as well to the same app and be all co-located together?
So Ethan, I apologize if I misspoke there. So students will not need to fill out the symptom checker.
Okay. Okay. And so understanding that now responding to Aaron, understanding that students are required to fill out or to comply with the surveillance testing if they fall into those categories of distance from campus, engagement with campus. I think that there really won't be a problem with students either using the app or the website. I agree with Lamar that the website does help for students who might not have access due to phone limitations or lack of wanting to share personal information on an app format. But I think because there is that requirement to be engaged in classes that they are in compliance, I don't see an issue with students not complying with the app or with the website protocol.
And it's really that's the key to this whole thing, right? There's not going to necessarily be people standing outside every building checking your little phone, right? It's that student affairs knows if you're compliant or not. That's really the mechanism that will drive all of this, rather than any meaningful level of building access monitoring or anything like that. The logistics and stuff behind that are not feasible on a campus of this size.
So one of the things that's in play right now is Radius, that's doing the volitional saliva-based testing, is using an app-based interface right now for their resulting and for their testing. So I think that that's actually been really helpful for us to get us off the ground, for getting people kind of assimilated with this kind of a procedure. And the feedback has largely been positive from students on that. It's very easy, it's integrated. We've actually received we've done our own kind of, field questioning, and our interface looks favorable for students. And so we really want to encourage that student experience to be maintained.
Would you notify a faculty member if they were teaching in person that a person they were about to teach was non-compliant?
I am not sure about that. Can I take that question back? Because I don't know what that would look like.
Yeah, the fundamental issue, what Amir said is right. We need to take that back, Aaron. The fundamental question there is, what window is the campus going to allow between technical non-compliance? If I'm compliant at noon today and I become non-compliant at 12:01, how long do I have to become compliant again? That's a question that, to my knowledge, has not been answered, but is an important one to answer. And we will take that back.
I think there
just
will
to add
be. Yeah, Audrey, I was going to go to you, thinking that maybe the ambassadors would be involved in checking people going into buildings and things like that.
I mean, we had talked about that, if we feel it's necessary, as one of the volunteer service corps potentially could help with that. But I hear Ian's point too about the logistics and where can you do that. But I know, I forget, Amir, who it was that we talked to, if it was New Hampshire. So one of the universities we talked to about this was just saying that professors were not happy about having to be the enforcers, right? Like, they did not want to be the ones to have to check the hall pass and kick someone out of class if they weren't in compliance. So thinking of other ways, and it may be, that it's going to come down to you're no longer able to access Sakai. I don't know, or you can't get into certain elements on campus that you need to do your work if you're not in compliance. I don't know.
So this group knows, Ian, Amir, and I have a conversation later this week with our folks in student affairs and University Counsel's office to go just into those things. So we should have some of those additional answers then.
And Lamar, your question. So I think that there's two ways that the CDC talks about quote unquote clearing someone from isolation. So one is what's called a test-based strategy. The other one is called a time-based strategy. The preference from the CDC and from almost everyone across the country is time-based strategy. So it's that 10 days with at least 24-hour period of without having a fever and improvement in symptoms. That's when you can come out of isolation. So testing to be negative to come out of quote unquote isolation is actually not recommended. The reason the 90-day window is picked after testing positive is there are some instances where people can shed very, very, very low levels of the virus, but we've gotten so good at picking up the virus on PCR testing that that's why we don't recommend retesting within 90 days, because you can get into a lot of things called cycle threshold, et cetera, when you talk about that, but it hasn't been shown to be helpful in actually getting people out of isolation faster.
And Amir, this is particularly for our student colleagues who are on this call. This would be a good time for us to be specific about that definition of 10 days. What does 10 days mean? Because that will be an area where there's a lot of chance for misunderstanding, shall we say, definitional misunderstanding.
Yep. Yeah. And so what 10 days means is we usually from the date of your positive test would be considered day one. So going forward on a calendar 10 days from there, that's when you would want to quote unquote isolate. And when we say isolate, it's really trying to do as much as you can to limit your interactions with people, try not to have shared congregate living areas like kitchens, bathrooms, etc. And for a 10-day window, continue to monitor your symptoms and make sure that you're not getting worse medically. That's what that 10-day window really affords you and really buys into.
But
and then after that period,
pragmatically, most people will feel like it's 11 days.
That's correct.
It feels like it's 11 days. That's what I really wanted to get at. And people are going to say, this is an 11-day quarantine. And no, definitionally, it's a 10-day quarantine, but it's going to feel like 11.
It is. It is. Thank you, Ian, for making sure that that's there. And part of this too is that we want to do what's right. We want to make sure that you're having check-ins with care, and then making sure that you're doing okay. So Ryan, actually, it's not necessarily longer exhibiting symptoms. So the definition of clarity is, or I'm sorry, clearing for an infection is 10 days with at least 24 hours. I can actually pull up the CDC definition. It might be helpful for everyone to see it. And I'll go ahead and do that right now.
Mimi and a team of the chairs, what would be helpful from us? Would you like us to say, this sounds great. This is a really good plan. We are recommending, this has our support?
Yes, I think the provost would like to hear that, would like to hear, or if there are, one of the things he was asking about in particular was the mandatory nature, who was designated as mandatory for testing, the timing of the testing, those sorts of things. If we were kind of in agreement with what is being suggested for who is mandatory, who's not mandatory, and how much mandatory. So
I think it would be helpful just get a summary from either Amir or from Ian of that. You know what I mean? Like we've talked and asked a whole bunch of questions at this point. If they could walk through, this is the testing protocol, this is who will be included, just so we're all clear of what you're asking us to support.
Okay.
I think also just Audrey raised a fantastic point in the chat, which is that an educational component, students will have to need some, whether it's videos or something explaining all of this. They will need a point by point breakdown, probably, or maybe even required training, honestly, something that walks them through point A to the very last point of what will happen.
Absolutely. And that's what we're working with our communications partners on, a very thorough hub of information, a wheel that you could go to that everything is there, including educational information on how to collect a swab, etc. So just real quick, so I can show you, and then I'll do exactly as we had talked about. So here is what the definition for isolation is. Can be discontinued 10 days after symptom onset or test, and resolution of fever for at least 24 hours without the use of fever reducing medicines and improvement of their symptoms. So you could still potentially have a mild headache, but if you started with a severe headache and you got a mild headache now, you're improving your other symptoms. And as long as you haven't had a fever, that's when the 10 days is removed. So again, this would be working with our partners in the county, because at the end of the day, the Orange County Health Department or the campus health is the one who makes that distinction with saying that you're out of isolation. They would be feeding us that data. So we would have solid data on who is removed. We wouldn't just blanket 10 days for everybody.
Ethan has his hand up.
First, I'd like to just say that I very much support what's being talked about right now in the chat of the of a video tutorial or a video training that has to have some mandatory compliance before the start of courses, just like are done with the alcohol EDU and sexual assault prevention courses that are required of students. I think that's a very good way to make sure students have to understand the protocol before going into the semester. But on the vein of feedback, I would like to push back a little bit against what was talked about for students living in outside counties, who are then going to be required to test once a week. I think that will cover more students than is anticipated who are not accessing campus whatsoever, including students who might normally require to live on campus in dorms, but are not being afforded that option in this coming semester, are living at home or living with family and not accessing campus whatsoever, but then being asked to come to campus once a week to find the transportation to do that just to get tested. I wonder if that could be solved by having some kind of off-campus testing option that they could submit test results.
I think the idea is that unless they are coming to campus for a reason, for class, for using the library, whatever, they're not required to test.
No, they are required to test based on the county that they're living in, regardless of whether they quote anticipate coming to campus or not. And the rationale there, and again, this, Ethan points out another one of these major headaches that COVID brings us. But the rationale that we came to is that particularly for undergrads, even if they're not coming to campus, they're very likely to be interacting with others who are, or they're very likely to be interacting with others who are then interacting with others who are, and it all ends up back on the campus. And because COVID is so highly transmissible in the asymptomatic phase, that this was what we felt was the best compromise in terms of keeping the overall community safe while mitigating the inconvenience to students who are truly not having any interaction. We are planning for one of these test facilities, as we say, to be readily available just off Franklin Street with free parking, so that we're trying to minimize the headache to the extent possible.
So maybe it's worth me walking through. Oh, I'm sorry, Ethan, go ahead.
I'd just say that in that case, I would strongly recommend that resources be made available for students who lack transportation, whose parents can't drive them, who don't own a car, who have to pay for bus tickets.
Absolutely. Absolutely. I was going to chime in and just say that we saw this at the beginning of last semester when we had to drive up for your mask and your hand sanitizer. It was the drive up stations. Many students were ineligible to get them because they didn't have transportation to drive up to get the mask and the hand sanitizer. So they had to find other means of getting that stuff.
Can I weigh in here too? Staff have the same issues with the drive up situation because we have a lot of staff who don't drive. And I'm also being privately prodded to ask the question, could you please clarify staff requirements for testing, working remote staff or just working on site?
So let me just start over then with the testing requirements, because I think we've got a lot of questions about that, and maybe we can just walk through each layer of that just very clear and concisely so that we answer all of those. So I apologize for not doing a good job of this before, and I'm happy to go over it. So
I think you've done a great job. I don't feel that way. I think
no. This is complicated, and so I think the more times we say it and we reiterate it, I get myself kind of confused whenever I think about this. So I hope you can hear my daughter in the background. So I'm trying to balance this out, such as the world with COVID. But undergraduates who are living on campus, having in-person classes, or that are living in congregate houses that have more than 10 people living in them, twice a week, 2 times a week, so every 72 hours, undergraduates, okay? Undergraduates right now, in terms of what we think of in terms of a potential draft, would be undergraduates that are living in Orange, Chatham, or Durham counties. So this is where Ethan's feedback and Lamar's feedback, I think, is really helpful here. You're suggesting that Durham and Chatham counties are too far, potentially, but that we should focus only on the Orange County component of that. Is that what you're mentioning?
I'd say even in that situation, there are students who don't have access to transportation or who might logistically have difficulty balancing that coming to campus with other part-time jobs or even just classes. So I think there just needs to be greater thought about what resources can be made available or accommodations in testing times so that those students do have the ability to comply.
Okay. Thank you for that feedback. I think it's a really important thing for us to take back and to consider, and like how we can make that a little bit better process for everyone.
That's undergraduates who are living in those counties, regardless of whether they're accessing campus or not.
That's correct. That's correct.
And I just wanted to say something. I think Aaron raised this point earlier, but and it may just be logistically harder to figure out how to capture those, but I'm wondering if there would be consideration of, rather than a county-based approach, it's a radius approach, because there's certainly parts of Alamance County that are closer to campus than parts of Durham and even Orange for that matter. So I'm wondering if the county by county approach is the most effective way to do that when you consider who's living close to campus.
Yeah, I think that we're open to considering the geographic radius idea too. We thought about that at the very beginning. It gets very confusing to spit out a formula for 30 miles, whereas you could definitely look at a town and say this is in Orange County. So when you're thinking of 15,000 students and you're trying to do geo mapping for all 15, it takes a considerable amount of effort.
We did also get data from ISD, which shows the rough geographic location from which computers were accessing the campus infrastructure. And those data indicated that we would get most of our undergraduates by going to those 3 county areas, and that the relative value of going to Alamance or Wake County or one of those others was less than staying with sort of the core 3 counties. So, to the extent we can be data driven, we try to be, even when the data are fairly minimal.
Amir and Ian,
Bringing up the idea of a exception process for some sort of individual challenge.
I see that Kim had mentioned that about exceptions, so that's a good point for us to consider too.
Is there any coordination with Durham, Orange, Chatham County, Department of Health and Human Services? Is there any way that they could perhaps get tested with these departments and submit the results or submit the testing from those departments if there is a testing site that is closer than the testing site on campus, just to kind of help those students where transportation is an issue? Is that a possibility?
That's a really good point. It's a great consideration, and I think we would have to figure out the logistics of how to do that. And what we don't want, one of the things that we really value in this process is that the testing that we're offering to students is not at a cost to the student. And so, again, if we had unlimited resources where we could go and do mobile testing at every single one of these places, trust me, I'd be the one driving the bus to go do it. I would love to be able to do that, but it's very difficult, I think, when you think of the logistics of trying to coordinate that, how we can do that in an effective manner. Because if my mobile unit comes out and it's only there for 3 hours in a day, we're running into that same time hurdle that Ethan was mentioning. If I've got my classes and this is my window and you're only coming on Monday, that might not be good for me. So I think that we'll try to figure out the best way to address that for sure. Aaron, did you have a question as well? I saw your hand.
Thank you. I like very much the geography, but I want to try to accommodate what Ethan is concerned. I do think we need to test those in the geography because they might still be going out to bars, still be hanging out with friends, but not coming to campus, so we don't test them. That doesn't seem right. But maybe if there's an exception, they tell us that they live at home, that there's no other students in their household, and they agree not to come to campus. If you live in Wake County with your parents, and you just you're close enough, but still choosing not to come, maybe there's a way.
That's a good way.
Or could it be the case that you give them 4 vials and they are mailing you what they did for their reentry weekly? And that is their way of testing remotely if they're unable to drive over. I hadn't contemplated you'd have to drive from Wake County once a week to get tested. But I do want you tested if you're living close by and engaged with other students.
So Lamar, again, it's a lot about this is cost. So if you were to go to a UNC facility right now, if you were to get tested at a CVS or another testing place, you may incur a cost for doing that. What we're doing with our homegrown testing is that we are processing these samples in our lab and that we aren't billing the students for these costs. And so that's a key component that we're trying to work on.
And as much as I'd like to claim otherwise, it will be way more inconvenient for somebody to try to come into a UNC clinic or hospital to get tested than to go to one of these sites.
Yeah, and
they will definitely be waiting longer.
And they do the nasopharyngeal swab, which I would hope that people would not want to do. We would be doing the smaller one. So let me just get back to the people again. So we just talked about undergraduates. Graduate and professional students who are accessing campus to teach, be a lab TA, go to a lab, do classes would be 1 time a week. Graduate and professional students that are living in Orange County but not accessing campus could be volitional 1 time a week. Now, we had talked and brought up our health affairs graduate students in this, and we would say that we would work on the exclusion of health affairs students that are graduate students because of the way that their symptom checker works, et cetera. They have another portal in terms of being able to monitor on a daily basis. And then the last bucket.
Can I just say one more
staff-
thing? Can I just clarify that category you just said? So
Yeah.
there are undergraduate health profession students too. So are you going to say they're going to fall in the health professions bucket or they're going to fall in the undergraduate bucket?
Can you describe those students to me? Where are they housed? So are you thinking like nursing? Is that one of the ones that you're thinking?
Yeah, nursing, clinical lab science, radiologic science. Yeah.
They would need to follow the undergraduate because it's patterns of behavior that define the disease transmission and living conditions. And we know that the undergrads will follow undergrad behavior
Yeah, so
patterns.
this is just an example when communication needs to be really clear. We can't just blanket health professions. We'll need to say undergrads or grads. Okay, thank you.
So would health affairs graduate students be the right terminology?
I think we probably need to discuss this offline because we've got
Okay.
another health professions group, just because we've got so many variations on the theme of who's on campus. I mean, we have graduate students coming to class and labs every day in the health professions. Why would they be any different than our undergrads? So we can discuss this, I think, at a separate time so we don't take up the group's time.
Thank you. Yeah.
Joy, the comms people we're working with on this are the same folks who are working with the health group that I think you and Audrey are part of, behavioral health comms group that's dealing with this.
I'm not, but I think Audrey is. I'm not.
Okay,
Yeah,
so
we don't have
I think that's important, and we'll reach out, Joy, to. I think
Yeah.
what you're bringing up is important.
Yeah, we meet every Wednesday at 9:30.
And then,
Dr. Barza, if I may, the graduate and professional students living, not accessing campus, you said Orange County. Is it just Orange or is it that same 3-county?
well, so it's a volitional testing there. And so we thought that vote could be a little bit smaller since it's not mandatory, right? And so we just said Orange County again on that one.
Okay. Thank you.
And then our last bucket, staff and faculty, again, with the idea that they would be performing a daily symptom checker regardless of testing. If you're accessing campus, you could be a volitional one time a week. This wouldn't be mandatory. If you are completely remote and you are in Boone, North Carolina, doing whatever you need to do your job, but you're staying in the mountains for the rest of the foreseeable future, you would not have to be involved in any volitional testing if you didn't want to. Again, we think it's an important opportunity to provide our staff and faculty if they would like to, but not keeping it mandatory.
Can I just ask for clarification? Because it's partly because I wasn't listening carefully enough. I was writing notes. But for people who are living in an adjacent county, I'm talking about faculty and staff who are living in an adjacent county, but are never going to go to campus. What's their situation?
You wouldn't need
No
to.
faculty and staff have to get tested, period. No faculty and staff have to get tested. Faculty and staff who want to get tested can be tested up to once a week. We would honestly like to discourage it, right? Like, because we know they're not going to be a significant part of campus transmission. And we also know that they're not at any significant risk of getting COVID by being on campus or interacting with students. And we know that again through 9 months of clinical interactions within UNC Healthcare. We see the incredibly low rate of transmission from patients to staff within the healthcare setting. So based on that, we would actually like to discourage faculty and staff testing, but we can provide testing up to one time a week for faculty and staff who would like to get that.
Aaron,
Again, just to be clear, you're saying faculty and staff that are accessing campus are required to do the symptom checker. Because I do not think that is clear to
Yes.
faculty and staff right now. I mean, it is to those of us who've had this.
Hey,
It is currently not a requirement, Joy.
Okay, so
this will
so
be
they're not
a new thing. It is available. What we have found out through working with HR, the symptom checker is on, I forget which website, maybe it's the
DHS.
HR website, but
It's
it
on
is.
DHS.
Yeah, so it's available for faculty, staff now if they want to use it, but it's not been required.
But it will be as of January.
Yes.
Okay, thank you.
so those are your big groups of people. So you've defined your undergraduates, your graduates, and your faculty and staff. And Aaron, you're absolutely right. Voluntary testing is the way we should refer to it. Thank you for clarifying that. I'm glad that you said something.
His hand's actually raised right now if he has a question.
I do. Thank you. And I was Googling volitional, so I'll use my volition here to say, I think in all the chat I've watched, our comments have been around the edges about whether you do have to drive from Wake County is included. But in the main, it seems like this group here has been very supportive, just reading through that comment set. And I think that we should express our strong support for this plan as put forward. This is really thoughtfully created. The privacy issues, the app and web, the who does and doesn't. I would have expected faculty and staff to test, but I understand we're going to use the science and not just my gut feelings, and I appreciate that. And so I hope that we could make a recommendation to proceed with this.
I agree. I was about to say the same thing until you were recognized. I think this is really good, and we should encourage individuals to volunteer for this. But so far, just by looking at it and hearing you describe it, it seems like you took everything into account. And yeah, this is not perfect. There's no way to make it perfect. But just right now, it just sounds like this is pretty solid. And thank you for the work that you've done. Thank you so much. I would support this.
Can I just say, and just before we go forward, I want to say on behalf of the Chancellor and the Provost, who you all know I'm sitting here on behalf of, Ian and Amir have picked this up, and what they have done in the last month is unbelievable. For those of you who don't know, we're setting up our own lab on campus, and Amir talked about that. That'll be up and functioning by Christmas in the Genome Science Building. So the fact that this has all come together so quickly, these two gentlemen have really stepped up, and they also have day jobs that have nothing to do with this. So, I want to express gratitude on behalf of the Chancellor and Provost just for that.
It's really amazing. We said that, I think, yesterday, actually, at the Faculty Executive Committee to the Provost. It's kind of amazing what has the investment that's been made and how sensitive people have been to concerns. So it is remarkable, and thank you both for all your work. So
I just one other thing is, when this gets communicated and rolled out, just because we do have inquiring minds on this campus who are suspicious of most everything that happens, that I think it will be helpful to provide the science. So if not testing faculty and employees, staff period is in science somewhere, or we have it documented, other campuses have not done it or have done it, I think it will be important for people to know why you made the choices on the populations you're testing and why you made the choices on the populations you're not testing, to help people start feeling secure of where the direction of this campus is going for January.
Thank you for that.
May I ask also, could it be that departments do something different? Like the housing staff might choose to all test since they're going to interact with people living in housing, or that there might be departments. I appreciate that you're going to allow it, and maybe individual departments might encourage it, at least particularly on a restart.
So I would be remiss if I didn't speak up on behalf of staff. I've gotten more feedback than I care to share right now, just listening to the last comments about staff are being discouraged to utilize the voluntary testing. Without revealing any sources, I have somebody who's on staff who just found out about a half an hour ago that a family member died of COVID. This person is in a high risk category, will interact with students as they come back to campus. So I think we need to really think about, when we make this recommendation, what message are you sending to those high risk staff who already feel marginalized and left out of this conversation, who may or may not be more affected than we are in our slightly privileged situations here? So I would be remiss if I didn't share that information with you, that is going not to That is not going to go over well with people who already feel vulnerable and who had a very bad experience in the fall when clusters started showing up and spikes started happening.
So I appreciate that very much. And I think one of the things that we were leaving on the table, the opportunity to be tested. We were trying, I think part of this is also being cognizant of the fact that I think we took it a little bit of a different approach. If you say that people are required to do mandatory testing, I would feel really bad if that was the case and someone lost their job because they missed a test. And so we do want to leave the voluntary option as open as possible. We also have really good data that if you do the symptom checker and you're doing that on a consistent basis, it does protect you quite a bit and it does help you quite a bit. And so I agree, if we want to, that offer and the opportunity is there for staff to be tested weekly if they're interacting with the campus. And we should encourage that.
I understand what you're saying, and I absolutely appreciate it. I think there's a large amount of staff that would agree with you that if they have no interaction on campus, they should not be forcibly tested. I get that, but please understand there is a large there is a population of staff who could not get tested in the fall when spikes were happening. And if they hear that they are being discouraged from testing, that's the language that I think we have to be very careful about. This population already felt left out of the equation and were very afraid when the clusters started showing up.
Yes, I agree. And I apologize for the term that was used in discouraged testing. That we should not use that term. You're right.
Agreed. I was the one that used the term, and that is not that shouldn't be the university's stance. I'm saying from a purely scientific and operational standpoint, that could be discouraged, but we're definitely providing that testing once a week exactly for the reasons that you lay out. And no one is advocating that the university or any department should discourage staff from being tested.
Yeah, from the university perspective, Shana, any of our communications will be very clear that this is available to all faculty and staff who are coming to campus on a voluntary basis up to once a week.
And I appreciate that, but I'm sharing this information about the perspectives of these folks who had a very bad experience in the fall, because I don't think that's widely known. And so they are very insecure about this spring and they are very worried.
Yeah.
And I think the communication around this will be critical to its acceptance with staff.
Yep, I could not agree with you more. And I appreciate the sentiment. I totally agree with you. I've had those conversations with our clinical staff as well and our clinical departments, because the fall was really, really tough when we were looking at it from an aspect. And I felt I helped with the respiratory diagnostic centers in the area, and our criteria for testing would consistently change and constantly change. And I think that we are in a better state than we were before in testing supplies and availability. So my goal would definitely be to make people feel safe and to offer that testing opportunity. And I wish that we could change what the fall was, because I do feel like we're in a different setting now than we were in the fall. My hope is that we walk into the spring with the ability to be open to the idea that this is a plan that is different than what was in the fall, but also one that we hopefully can give people both peace of mind and then also an understanding that the intent is to keep the university as safe as possible.
Great. Thank you for hearing my concerns.
Yeah, absolutely.
Just one other communication thing is we've heard over and over that symptom checking is excellent, et cetera, but we're only requiring that for faculty and staff. We're not requiring it of grad students. We're not requiring it of undergrads. So again, it's the messaging of saying this is great, but we're only doing it for this group. We're not doing it for this group. It's just making sure people understand why these decisions are being made.
Sure.
Okay, so it sounds like we have, we are as a group, based on the chat, based on what people are saying, the caveats that have come up around that Amir and Ian are going to take back and work on some more caveats around language, making sure that people understand that things are different than they were in the fall, that those sorts of things, that we think that this is a pretty comprehensive plan, that there may still need to be some tweaks, but that we're more than generally in support, that we're in 90% support of this with addressing some of these questions. Would that be a good reflection?
I'd say we're even stronger than that, but.
Okay, good. So more like, okay. So we feel like this is 95% of the way there with making sure that it's embedded within good, strong communication, clear communication about why we're making decisions, some exception processes for students that may have difficulty accessing campus from different places and for different reasons, and to do a little bit of that problem solving. But otherwise, we're in support. Is that yes?
It looks like Sharon also has a question.
Okay.
I don't have a question so much, but I just wanted to support Shana for speaking out, because, and also want to bring up something that Lamar is saying. We need to understand that we're going back into the spring with real trepidation among people in terms of the perception of what happened in the fall. So our messaging must be absolutely clear, and we must have something rolled out that's going to tell students who are elsewhere and not on campus, but coming to campus, exactly where they can be tested, when they need to be tested, and how, and that needs to be clear. We can't, in a sense, do the work on the back end once everybody is here and say, oh, well, we've got a plan, they need to know when we roll things out where to go. And I think it'll be easier to protect everyone, right? If those most vulnerable are protected first. And I just want to reiterate that.
I think that's a great point. And I think we can ask people to come back to us and show us, related to the document that we're talking about earlier today, to show us exactly what does the Carolina Together website look like now? What are the prototypes around, just like you showed us, Amir, with the hall pass, to be able to actually see it and to see whether those things we think they're going to meet that threshold for increasing people's comfort.
And also, can I just say one more thing that just struck me? And it's everything is related, it seems. This concept of mandating testing for students and casting such a wide net as far as counties are concerned, that is related to, and please correct me if I'm wrong, Amir and Ian, that's also related to faculty as well, because if we know the status of the students for which the staff will be coming into contact with, then that better helps us protect the staff as well. But that is nowhere, trying to address, Shana, your comment, because that's still really important. But that is something that, I know is not necessarily communicated, that testing the student population is still very much beneficial for, protecting the faculty and staff, especially staff that they come in contact with.
So I would say that's probably one of the most important things that we are doing with a surveillance or regular interval testing program. It's just as important to find that positive, to be able to pull them out of the community so that the spread doesn't continue, as it is to protect the others in the community that are around them that may not be interacting with them all the time. So thank you for saying that, Richard. That's a very important point. And I think that's actually something that Ian and I need to figure out how to word with the communications team appropriately to highlight and to capture that point, because I think it's a very good point.
Joy, did you have another question? Your hand's still up. Okay. Sounds like we're maybe at a stopping point. Would we agree? Someone is wailing yes in the background.
My daughter also thinks that we're at a stopping point. So
Okay, all right. Well, she has the final word. Well, thank you, everybody. Appreciate this. We'll be in touch about plans for next week, and don't forget to refer your colleagues. All of these meetings are posted on the Carolina Together website, so people can go back and watch them if they weren't able to tune in today. But it may be very useful for folks to do that. Thank you all for your
question.
Pardon?
I may have missed this at the top of the meeting, but are you planning to finalize that recommendation document before next week?
Yes, and I'm going to finalize it with the co-chairs and send it on. I've incorporated most everyone's comments at this point.
Okay, thank you.
Mm-hmm.
From me and Ian, thank you for letting us be a part of this. This
Thank
was
you so much for coming.
was my highlight of the day. So thank you for letting me do this. Breaks the monotony of doing emails. So thank you so much for letting us present this plan. I really appreciate it. We've been spending a lot of time looking at it. We're trying to do good. And so thanks for letting us give the opportunity of sharing it.
I'm so sorry. This is the highlight of your day. We need to help you after COVID.
Yeah. Talk to me mid-February, let's say.
Okay.